The current state of the art, when I think about MPNs and when I talk to my fellows and colleagues about MPNs, we think about the field moving in several directions. The first direction is more specific and sort of user-friendly risk stratification. There's a lot of risk stratification scores out there for patients with myelofibrosis, for example. And the more we know about the genetics of the disease, the more we can understand those patients that are at higher risk, the more specific and sort of user-friendly those scoring systems are. Those scoring systems not only prognosticate things for patients, but also provide very important tools to use for when we are going to intervene. And the most important outcome, or the most important decision point, in my opinion, for when to intervene on patients with myelofibrosis is when to move patients to stem cell transplant. Stem cell transplant in myelofibrosis has become safer with the use of Ruxolitinib before transplant. For example, there's some evidence that that's beneficial. There's also growing evidence of doing, for example, haplo-related transplants in myelofibrosis. But the key issue remains timing. We don't want to take patients too early and expose them to the unnecessary risks of transplant when they might have years and years to do well. But we also want to make sure that those patients whose disease is moving towards something more severe, something perhaps like a transformation to acute myeloid leukemia, get the benefits of a curative therapy before their organ systems are damaged by that disease. So I would say the second big trend in the research going on in myelofibrosis is how to best understand the timing for more significant interventions. And then, of course, we're learning a lot about novel therapies, ways to use, for example, the BCL2 inhibitors like navitoclax, alternatives to the JAK inhibitors, novel agents, way to use some of the targeted agents that have been improved in AML, for example, the IDH inhibitors, and how to combine these agents. So with more and more therapies, there are options, but we're still not sure about how to combine them safely and what's going to really prove to be the most beneficial. And finally, I would say the patients who are the greatest need, of course, remain those who are transfusion dependent because of late stage myelofibrosis or more advanced myelofibrosis, and figuring out which agents are best able to manage anemia, and those who have transformed to accelerated or blast phase, where the outcomes are still dismal. So those four areas of research remain the ones where the community is focusing the most energy right now.